Oh, there it is.
Hi, everyone. Thank you for joining. Just a bit of housekeeping to start. Please put any questions in the chat, and our panel will answer them after their short presentations. I'll wait one more minute, and then I'll introduce our panel because I see people are still joining. All right, we'll go ahead and get started. Thanks, everyone, for joining. And again, you can put any questions in the chat, and we'll answer them at the end of the presentation. Now I'd like to introduce our panel. So we have Dr. Kevin Shea. He's a pediatric orthopedic surgeon specializing in sports medicine and specifically in knee surgery and knee anatomy. And he also frequently publishes research on pediatric knee anatomy and the latest surgical techniques. He sees patients at our Stanford Medicine Children's Health locations in Burlingame, Sunnyvale, and Palo Alto. And Tim Liu is a pediatric physical therapist, and he specializes in helping kids recover from orthopedic issues and sports injuries. And he's also a certified strength and conditioning specialist. He sees patients in our Sunnyvale location. And Deborah Callahan and Jeff Morgan are athletic trainers who specialize in biomechanics and return to play decisions for young athletes after injury. They see patients at Stanford's Motion Analysis and Sports Performance Laboratory in Sunnyvale. And without further ado, I'll hand things over to Dr. Shea.
Yeah, can you hear me okay, guys? Can you hear me? Okay.
Yeah, you're great, Ken. Yeah.
Great. Sorry, guys. I'm not sure. I'm having a few technical difficulties here. So hopefully the slide deck is going to show for you. I'm going to share the screen of the slides, and you guys confirm that you can see here. Let me just pull up the share screen option. It's great to be able to join and collaborate with all of you. I'm really excited to be here. So let's see if the screen share.
It's working.
Very good. And now I'm going to see if I can expand these slides. And okay, you can still see the screen and the slides?
Yep.
Okay, all right, we'll go. Well, welcome everyone. And we have a lot of questions about pediatric and adolescent patients with growth plate injuries and who also have ACL tears. And this talk is really designed for people who have kids with open growth plates, parents, therapists, and other people who take care of young athletes. And for people who have really questions about ACL injuries, we're going to try and cover a lot of that today. So what is the ACL? This is unfortunately one of the most commonly injured ligaments inside the knee, and it's ACL stands for anterior cruciate ligament, meaning it's got a crossing pattern inside the knee. It's a major ligament to stabilize the knee, and if you're an athlete and you perform high demand sports, if you injure your ACL, your knee's probably going to feel less stable if you try to go back to sports, and your knee might feel like it gives out or shifts or buckles. It just doesn't work right. The ACL injury mechanism in some ways is kind of a partial dislocation where the shin bone, you can see on the screen here, the shin bone shifts to the front and partially dislocates, tearing the ACL and sometimes causing bone bruises or meniscus tears. So we call it an anterior subluxation and rotation or twisting. And you can frequently on that lateral part of the joint or the bone condyle area, we see a deep bone bruise both on the thigh bone and on the shin bone. And so pretty commonly seen with kids with ACL tears. Well, when we see these, what do we do? How do we evaluate them? How do we treat them? Well, your history is pretty important. You'll get an examination, and in many cases, you may get x-rays, but most times an MRI can be very helpful to help with the diagnosis. MRI allows us to see a lot of the detailed anatomy, including meniscus, cartilage, and sometimes other ligaments in addition to the ACL may be torn. There's a lot of things we do to examine for ACL, and the history is very important, but one of the classic things we do, and you may have read about or heard about if you do any research on the internet, but called a Lachman test. And Lachman refers to a stability test to look for a torn ligament. And typically you'll bend the knee about 20, 30 degrees or so, get the patient relaxed, and you may stabilize the femur with your opposite hand, or you may stabilize it with your knee or stabilize against the side of the table. And you basically try to stabilize the femur and then shift the tibia or the leg part. and you kind of pull it anteriorly. We call it an anterior directed force, or like a drawer. It's like opening the drawer of a cabinet. And when you get the MRI, so after you've done the exam, you get the MRI, and you may see these bone bruises, and you can see on these red arrows, it's highlighting some very big bone bruises that occur on the knee, as well as the knee is bright white because you've got a lot of fluid and irritation there. So on the MRI, we can see ACL tears, these bone bruises. Meniscus tears are sometimes present, probably at least 50, 60% of the time. Sometimes you'll actually shear off pieces of cartilage in addition to tearing the meniscus. And not uncommonly, you have an MCL injury or a medial clavicle ligament injury as well. Well, let's say you've kind of gone down this path, we've examined, and MRI, we've confirmed you've got an injury, an ACL tear. Well, who needs an ACL reconstructions? Well, first we say is that there are patients, certain types of patients who will do well without surgery, especially if they are lower demand. A lot of times older patients who don't do high-level activities may do okay without an ACL, and we treat them with therapy. We work on reducing swelling, getting their strength back, really maximize muscle force generation and rehab such that the muscle stability may compensate for a torn ligament, especially if you're not real high demand with recreational sports or activities or things like that. But we may then direct those patients to, hey, you got to be careful. Don't pick up lacrosse or racquetball or running on the trails or downhill skiing. You got to be careful because your knee may give out if you do high demand work or high demand recreational activity. Well, what we find though, that regardless of age, if you have a sporting life, you have an active work that demands you twist, pivot, change direction, lift things, or you have recreational activities, you hike on a regular terrain, you run trails, you mountain bike, you're a skier, those patients may very well do better with ACL reconstruction because their knee is more stable. Sometimes we don't do the surgery right away, though. We might wait 3, 6, sometimes a little bit longer, 3, 6, 8 weeks to have some what we call prehab, or time to recover strength and motion, because sometimes the knee is really swollen and stiff. And we prefer to operate on a knee that's not really stiff, because if you're stiff before surgery, you're more likely to have a problem with stiffness after surgery, and we make the job for the patient and for the therapy team even harder. So sometimes we'll delay the surgery for a better outcome, sometimes as long as 2 months, 3 months sometimes. Once again, who needs surgery? Well, I think it really depends, but most younger patients, or really athletes, or anyone of any age who's really active, if they go back with an ACL injury to more demand activities, they're probably going to feel unsafe with high demand activities or sports. And if you try to go back without an ACL, you're more likely to cause further damage to your knee. You can shear articular cartilage, you can crack up a piece of bone and cartilage in the knee, and you can cause meniscus tears. Sometimes they're not repairable. So that's the downside to going back to high-level sports if you've had an ACL tear. Well, an issue that comes up a lot when we fix adults, we don't worry about the growth plate. We do surgery that drills right through the growth plate because it's not an issue in adults. But in kids, your growth plates make you grow. You get taller. The bones get longer. Every long bone in the body has a growth plate, and typically on the top end and the bottom end. And as long as these growth plates are open, you're going to get taller. When your growth plates close, you stop growing, and that's when you've completed your growth. So why are growth plates an issue? Well, females, typically, most females are growth plates are open to about 14, 15. There are exceptions. Occasionally I see a 17-year-old who's got an open growth plate. Occasionally I see a 13-year-old with a closed growth plate. Males tend to grow a little bit longer, 2, 3 years longer, and growth plates are typically open to maybe 15, 17 years of age, but some kids grow to 21. So these are averages, but there's always exceptions. Some people stop earlier, some people stop late. Well, why do the open growth plates matter? Well, surgical procedures can inadvertently cause damage to the growth plate and affect the growth plate function, and that may stop normal growth. Your leg may then grow out of balance. It might be short, it might grow with some angulation, with some flexion, some type of deformity, and could leave you with a leg length discrepancy where you're shorter on one side than the other. So we have to bear in mind that the surgical procedure I might do on a 28-year-old or a 35-year-old, I don't have to worry about growth plates. But in kids, within those age groups, I've got to worry about open growth plates. And it's not just the surgical technique, it's also what type of graft we choose. There are different graft choices. There's at least 3 or 4 different graft choices to think about. And some of these are better for growth plates than others. So lots of things to think about. Now, this is some historical literature, but between 1970 and 2000, most recommendations were don't do ACL reconstruction in kids because we knew that you could damage the growth plate, and these could lead to what we call varus valgus recurvatum. These are significant knee deformities. Many people have shown that. And we also show that a certain amount of cartilage damage, over about 7%, could cause growth plate problems. The other thing is you don't want to put bone graft or fixation devices across the growth plate, or the physis is the technical term. You can easily cause 2 to 10 degrees of angulation change within a year in a growing child if you damage the growth plate. So these are These are real numbers you got to worry about. So we have a pediatric patient that needs surgery. We want knee stability. We want to avoid damage to growth plates that lead to growth disturbance. And their options are to prevent any surgery around the growth plate, or to do growth plate procedures in which you drill around the growth plates, but you avoid. So this procedure is called an iliotibial band procedure. You do the procedure without any drill holes at all, so there's no risk of growth plate damage. And then there's what we call an all-epiphyseal, where you carefully place drill holes, but you avoid the growth plates altogether, both with your drill holes and any type of fixation. So those are kind of the two generic approaches we can use. So just some final comments. This pediatric ACL reconstruction is a technically demanding procedure, and you got to talk about growth plate problems because it does happen. And placing these tunnels, you got to be very careful doing them because you can cause growth plate damage and growth disturbance in the future. So there we go, Amy. We were right on 8 minutes, and we finished on time. So we're going to let Tim and Jeff and Deborah take over.
Thanks, Kevin.
Turn the screen back to you all.
Perfect. Let me share screen.
Great. Have you guys got the screen back?
I think if you go to your share screen button, there we go.
There you go. All right.
Let me get mine up. Thanks again, everybody, for joining us. It's a privilege to kind of share with you guys and speak with you guys today. I'm going to cover again more of the post-operative standpoint. Let me see. Did that expand okay? Can you guys see that full screen? Great. Okay, yeah. Perfect.
Perfect.
So I'm joined, I've got Jeff Morgan, who's our biomechanics supervisor for the lab, and Deb Callahan, who's one of our athletic trainers as well. But I'm going to go through the slides, but Jeff and Deb are going to be available for questions, especially with some of our lab related questions. So again, once Dr. Shea's done the surgeries, we work very closely together throughout this whole kind of collaborative care process from start to really finish in terms of getting an individual or a young patient potentially back to sport or back to whatever task it is that they're really looking to go back to safely after an ACL reconstruction. So I just kind of put together a really quick slide. Again, this is a really abbreviated version of kind of the things that we do within the physical therapy timeline after a surgery is done. But the time that's spent oftentimes with PT after an ACL reconstruction can vary depending on the demands of the individual going back to activity-wise, whether they're going back to sport or whether they're going back to maybe just some age-appropriate kind of regular activities, some running and simple jumping, things like that. But it could be anywhere from 6 to 12 months. And oftentimes for our higher level athletes, we're working with them at some point in some capacity, still into that 10 and 12 month window. But early on, a lot of our focus and efforts are really mitigation of some of the post-operative consequences. So pain, swelling, range of motion. We're really working on restoration of some of that straightening of the knee. As Dr. Shea mentioned, stiff knees going in become stiff knees on the way out. Knees a lot of times get stiff after surgery, and so it's our job to try to get them moving as quickly as we can and as early as we can so that we can get some restoration of day-to-day functioning. Kids may vary in terms of what they're able to do at these points, whether or not they're on crutches or whether they're able to walk. If it's purely just an ACL reconstruction, a lot of times we're able to have kids walking maybe within that first week. If there are other things like Dr. Shea talked about in terms of meniscus repairs or other cartilage considerations, there may be a time period where they're not walking and they have to kind of figure out how to get around on crutches and doing some of those things. A lot of our other early interventions really focus on restoration of some muscle strength or muscle activity even in itself after an injury like that. And depending on the graft choice that's used from the surgeon, the quadriceps muscle is oftentimes quite weakened. And so that's something we're trying to get going as early as we can and restoring as soon as we can, because that's going to be hugely important to restoration of function, especially athletic kind of maneuvers and jumping and running and some of those tasks later on in the line of the rehab process. Kind of our second phase really turns into more of a strength focused phase. Once we've gotten a lot of that mobility back and kids are moving around, they may look relatively normal kind of in day-to-day stuff, walking around the house, walking around at school. There's still probably quite a bit of strength deficit still there. So we're doing a lot of strength training in our PT sessions. Our PT sessions at this point kind of start to look almost more like gym training sessions or strength and conditioning sessions. Kids are doing different things with weighted things like dumbbells or barbells or kettlebells or leg press machines. We're getting them to be challenged a little bit because we want to try to build some strength in that muscle that's been weakened after the surgery, but also in preparation for just getting them stronger to protect that new ACL as they go back to the demands of sport. Once they've hit some strength milestones and we've gotten a little further down the line, then we start to introduce some more advanced strengthening things. We're still focusing on strengthening pieces, but we may introduce some some dynamic things like running and jumping. Some of the change of direction stuff is phased in a little bit later, as we want to be really careful in terms of exposing the graft to riskier situations. And so we want to make sure there's maturation time and graft kind of solidifying time before we expose the individual to some of those things. And then later on in the phases, it may be around that 9-month mark. For some, it's maybe a little sooner, just kind of depends on how well they're doing with the rehab. But we start to introduce some more sport-specific things. We start to have modified practice participations, and we start to have more communications with their athletic trainers. Within our organization, I think we have great partnerships with some of our Young Athletes Academy athletic trainers at our respective high schools that those trainers are working at. So it makes that transition process really smooth in terms of communicating between physician or orthopedic surgeon, our PTs, and then our athletic trainers, and how we're able to kind of to transition these individuals back to sport and not just take them straight from the clinic and say, okay, you're ready to go back to the field and back to practice. It's very much a gradation of sorts, and that's what we like to focus on and work on with our patients. Some of the things, let's see here. There we go. Next slide. In terms of objective measures that we really like to lean on, we try really hard not to lean on just time standpoints, knowing that a lot of times success is dependent on how well these individuals are doing on various strength tests. So we want to see restoration of quadricep strength, which is that big muscle in the front of the thigh to help with the knee straightening. That's a big predictor for outcomes for us, as well as the hamstring group on the backside. So we want to do some tests to kind of get really objective numbers in terms of side-to-side differences, but as well in relation to that individual's body weight. So we always tell kids, we want to see symmetry, but we also don't want to see weak symmetry. So if two kids have, got two really weak legs, they may be symmetrical, but it may not be helpful or beneficial for them to go back to a high-level sport if both limbs are pretty weak, and we may be putting them at risk for that. So we want to make sure we standardize it to that to some extent. And we also do some other dynamic tests, so some hopping kind of tests to see how well they're doing between the two sides on a distance, on a variety of different hop tests. And then a bigger one that I think we're building in more and recognizing more importance of is patient-reported measures. How confident are these athletes in their recovery process, in their abilities to return to some of these sport scenarios? Some of these high-level sports, and especially if an athlete was injured during that sport, there can be a lot of fear in terms of returning to that sport. And we don't ever want to put an athlete out into a situation where they're not feeling confident per se, or they're really fearful of a re-injury. Some of those things can be predictors for then re-injuring, even if they're testing really well on a lot of these other metrics. And then we're fortunate enough to be able to utilize some motion capture and biomechanics assessments that I'll go over in the next couple slides. But some of the risk for re-injury, again, our goal is to get an individual through this process and not see them back for a re-tear. It's something we hate to see, but the re-tear rates can be a little bit higher. And so we want to do everything that we can to mitigate those re-tear risks with what we know in the literature and what we can do from a strengthening standpoint and a preparation standpoint. So we definitely don't send anybody back to sport before the 9-month mark. We know that pretty well, that anything before 9 months, the risks are too high. And we certainly want to follow some of these testing batteries to make sure that we're making good decisions on when they're going back and if they pass some of these tests to go back and go back to sport successfully and hopefully mitigate the risk for re-injury. In terms of our biomechanics lab, so we're fortunate in our Sunnyvale space, as Amy was introducing, we've got a biomechanics lab with 3D motion capture, so cameras all around, and we've got some force plates built in. Really the purpose of this is to really have some objective ways to identify how individuals or our patients and athletes are moving through a variety of different tasks. So the biomechanics really looks at, how is this individual moving in space? How are they bending their knees and hips and foots and ankles and other joints? How are they moving around during these certain tasks? And we can look very detailed from one side to the other. And we can also look at forces when we have individuals do things on the force plates. How are the forces going through their legs, and how are they able to kind of operate through these tasks with those forces in mind? And so that's a lot of data heavy things, and that's why we've got a robust team in Jeff and Deb, and we have another physical therapist who staffs that team, and they're all devoted to basically these assessments and working with these patients to do those assessments. So we do an assessment kind of in open space. We have the patients and athletes kind of running on a treadmill, an instrumented treadmill that has force plates built in, so that we can look at the forces when they're running and their running patterns. We do a bunch of jumping tasks, agility tasks, some change of direction or some cutting tasks, because we want to see how they're kind of moving in space with those tasks. So this is a sample of just what one of our task assessment kind of pieces looks like. But you can imagine we do maybe, 8 to 10 different tasks. And so we get data kind of like this in terms of how they're bending their knee at what time point throughout the motion, how they're doing it between the right and the left side. And then I think we've done a lot of great work in looking at where is the power absorption happening? Is it happening similarly between the two limbs at the knee and at the hip? And so we're able to kind of map that and put that into these nice charts and then convey that to our patients and families, but more so importantly to whoever they're working with, hopefully to give some really, I would say, individualized and targeted kind of like areas to improve on in terms of cleaning things up, maybe in their movement patterns a little bit, to mitigate some of these risks when they do go back to sport. So I think the big advantage here is that we're able to kind of use some of this data to really customize some of the recommendations that our patients are receiving, and in turn really hopefully reduce those chances of seeing a re-injury. So these sessions are done, it's a couple hours that we do to typically take these, and then within a few weeks, a lot of times we'll have a follow-up meeting with the team to kind of go over the details of the report a little bit and go over them with the orthopedic surgeon and potentially with the PT or athletic trainer or strength and conditioning coach who's working with these individuals to then help tailor those recommendations. So I think that's it on slides. Yep, there we go. Let's see here.
Thank you so much, Tim.
Yes.
It looks like we have one question so far in the chat, and then feel free to, if anyone else has any questions, you can put them in the chat or the Q&A. I'm not sure exactly how it looks on your end. I'll read the question out loud. Can you provide a link or resource for best practices for the prehab that can be done before an ACL reconstruction surgery?
I don't know that we have a specific link. Amy, do we have any content potentially on the website? A lot of times I'll speak to just the prehab process. It kind of depends on like Dr. Shea said, how the patient's presenting. Not everybody requires prehab. I think there can be some benefit in terms of getting some exposure to the environment that individual may be doing in terms of rehab for much longer than after their surgery, so that it's not kind of a first time introduction on, we see our patients pretty much day 2 or 3 post-operatively. So it's nice to be familiar with the team that you're going to be working with for the long time kind of going forward. I do think any bit of range of motion work that you can get to optimize before the surgery and working on some of those strengthening pieces. Some of it, again, depends on other injuries that may have been sustained kind of with that initial injury that we may still want to protect that joint to some extent. So it really depends and is probably more of a case-by-case basis when we're looking at that question.
Yeah, and Tim, I might just add to that, but that's a pretty darn good answer, Tim, because I think it really is a custom decision based on how swollen the knee is. And a lot of times what the MRI shows, we see ACL tears that are minimally swollen and only lose maybe 10, 20% of their motion. And within 2 weeks, they've got full motion or almost full motion back. And then we see some ACL, MCL, bone contusion injuries that at 6 weeks, they're still struggling with some stiffness. And so it really is a personal thing. And I would say 90% of the time, we have a handout. We not so much a handout, but basically a series of directions that we send through our MyChart messaging to the family. We talk about it in the clinic, and then we actually send it to them. So it outlines some gentle range of motion activities, swelling reduction tips, riding exercise bike, things like that. But when I see a patient who's got multiple injuries and a really swollen knee, I'm probably going to send them to Tim and say, you need to see Tim for at least 2 or 3 visits and maybe 4 in the next, say, 3 to 4 weeks. And if it's a really tough problem, we'll actually have him see him more than that. And the reason that is that stiffness response is very unique. It's almost biologic. It's a little bit like skin color. We're all humans, but we have different shades of skin color. And some people don't get very stiff after knee injuries, and some people get terribly stiff. And we have to kind of adjust that on a case-by-case basis. And this one reason a lot of times we wait 3 to 4 weeks before scheduling the surgery. And occasionally with a really bad thing, I'll say, let's wait 6 weeks. And sometimes what we'll do is I'll have families text us through MyChart. It's a secure messaging feature in the electronic medical record. And if we push the surgery out 6 or 8 weeks, but by 4 weeks, they've moved a little further ahead, we may move their surgery up 2 or 3 weeks if we've got timed in the OR schedule to do that. But it's a very personalized custom response because injuries are unique and patients' response to injuries are unique as well. I see another question. We've got some good questions coming in. Should we answer another question, or Jeff or Deborah? Yeah. Did you guys
Kevin,
have some?
You want to take the graft choice? Do you want to take the graft choice question while you're on?
Yeah, that's a really good question, and it comes up all the time. And I'll start by saying there's no perfect graft. There's a lot of reasonable choices, but each graft has some compromises. Let's go through the three most common. I'll first just say cadaver graft in children and highly active young adults. The failure rate's about 3 to 5 times higher. So most centers don't use cadaver grafts unless you're a relatively low demand, middle-aged person, or maybe young adult, but very low demand. But as a general rule, cadaver grafts, they allow for quicker rehab, but they don't hold up to high level activity. So I don't use them much in my practice because most people I see are pretty high demand. So we'll start with hamstring grafts. Good graft, been around. We got a 30-year history of outcomes. Really nice in terms of recovery. Anterior knee pain is almost non-existent with a hamstring graft, so we don't have complaints of pain on the front of the kneecap. The downside is in young, high-level athletes for highly demand sports, say soccer, basketball, football, lacrosse, the re-injury rate's about 20-30% higher on hamstring grafts, especially if they're smaller in diameter. You can do things to make the graft diameters bigger, but the rupture rate in smaller diameter grafts are higher, and that may apply to women more than men. So, but that's one concern about hamstrings, but risk of knee pain is very low. Bone tendon bone grafts or patella tendon grafts, sort of the lower kneecap graft. Very good track record, 40 plus years of excellent results. The biggest problem with that is at least 35 to 40% of patients at 3 to 5 years, they still complain of knee pain over the front of their kneecap and the front of their knee. And they don't like kneeling on it, and they have a little ache and discomfort with activities, a long day of standing. So that's a downside, is the risk of kneecap or discomfort 3 years later, 5 years later, and in many cases, 10 years later, it's still there. It's not terrible pain, but it's enough to be an irritant. And so that's the downside to that one. Move up the kneecap a little bit to the upper part called the quadriceps tendon. So above the kneecap instead of below the kneecap, the quad tendon. Got a pretty good database over the last 10, 12, 15 years. It's been around for 30 plus years, but has gotten a lot more attention and a lot more utilization here in the last 10 years. I held off on doing a lot of those until about 8 to 10 years ago because I wanted to see the data come in showing how good it was. And over the last 8 to 10 years, the data on it's quite good. Anterior knee pain is really not much of an issue with that graft. The risk of a kneecap fracture is very low risk with that graft. And the re-tear rate seems to be as low as the kneecap lower tendon, the patella tendon graft. And so it has all the benefits of low re-injury rate. It has the benefits of no knee pain. The biggest problem with it, it leaves an uglier scar. It's in a part of the knee where the tissues spread. As you bend and straighten your knee, you stretch the scars. And so the ugliest scar by far is the quadriceps tendon graft. Even with all the plastic surgery techniques and other things we use to close it, the movement of the knee stretches the scar more so than the other two scars. The other two scars, especially the hamstring, almost completely disappear in most patients, but the quadriceps tendon is an ugly scar. And so that's the downside, is cosmetic, but from a functional re-injury risk and pain issue, it's a great graft, but it does leave an uglier scar. So Tim, you have some experience with this as well. You know, Jeff, Deborah, you guys have been seeing a lot of these patients, but love your thoughts if you guys have some ideas about optimal graft choices.
Yeah, I mean, I think, Kevin, I think you spoke to it a lot in terms of expectations, in terms of some of the knee pain considerations. I think the hamstring ones, at least in our practice ones, sometimes do better earlier on. But again, I think that they do struggle with some of the hamstring strength recovery in the long term. Yep. With a lot of our quad tendon grafts, I think we've been seeing some promising things in terms of maintenance of hamstring strength throughout the whole process, and that the quadriceps strength is making good return. I think the downside is the scarring, and that's the biggest comment from a lot of the patients, is didn't expect the scar to be kind of as big as it is and stretched out as wide as it is at that spot on just on top of the knee. But from a functioning standpoint, I think we're seeing really good outcomes with them. But we've seen kids be successful with all three, I would say with the patellar tendon, with the hamstring, and with the quad tendon. So I think it's somewhat of a decision to be made. Again, depending on the sport that they're going back to and depending on the family's preference for some of the outcomes potentially. Yeah. Jeff, you have any thoughts? I'll ask Jeff first and Deborah second. Any thoughts about grafts?
I would say that maybe a little bit longer recovery arc from the early onset for the quad tendon grafts. They struggle a little bit more with strength probably in the earlier parts and getting that quadriceps strength back compared to the hamstrings, which is what we have the most data to compare against in our group. But I think they're doing well when they do come back. It's just maybe a little bit more frustrating, or it takes a little bit longer time to meet those, limb symmetry goals as far as the strength in the quadriceps.
Yeah. How about you, Deborah? Any reflections? You've got a lot of experience here.
Yeah, I was just going to speak to the bone, patellar tendon bone. I definitely, in my experience in kind of getting athletes closer to that return, that anterior knee pain did seem to be a bit of a barrier. A lot of them tend to develop some of that patellar tendonitis or tendinopathy, and just some of that pain on the front of the knee with functional positions and kneeling, like Dr. Shea said. And I have experience where that was a bigger barrier, and most of my experience was with bone, patellar tendon bone, and rehabbing those individuals. And I will say I haven't really encountered that nearly as much as I see more and more quad tendon grafts.
Yeah. I've been doing ACLs for almost 25 years, and I've done probably close to 700 bone tendon bones earlier on in my career. Did a lot of them early on in my career, but less later on. I've done probably about 1,500 hamstrings, and now I'm probably pushing 400 quad tendons. I've done them all. I think they're all good choices for knee stability, but if I was going to choose a graft for me, or let's say my wife or my son or my daughter, I would choose a quadriceps right now based on my clinical experience, but also what the research is showing. That could change based on other data coming in, but right now for most of my patients, I would choose a quadriceps tendon, but there are always exceptions, and sometimes patients have preferences. But if I had to fix my own ACL right now, if I tore my ACL, I'd have it fixed because I trail run and ski, and I'd have a quadriceps and wouldn't even think about it. So I would just make sure I went to a surgeon who did a lot of quadriceps grafts. But otherwise, that would be my first choice. We got quite a few questions coming in here. Tim, you want to? The next one is on what would be the biggest difference in under 12 teen versus adult rehab. I understand it depends. So very good question.
No, great question. I think that's a really good question. I think a lot of this, in terms of the age differences, probably starts to show a little bit more into that strength phase, that kind of after the first month phase. And a lot of it probably goes back into the training experience of the individual. So, some of our older kids have probably had some exposure to some strength training interventions already at that point. And so we're able to maybe utilize some of those a little bit differently. Some of our older kiddos are going to definitely be utilizing, barbell-based lifts, maybe a little bit more so. Some of our younger kids are, we're going to still work on the same concepts in terms of quadriceps and hamstring and gluteal strengthening, targeting things, but we may do those in different capacities where it's, maybe it's a little more body weight focused early on, or we're utilizing some more machine-based things like our leg presses or things that are going to be in safer constrained situations for them versus bigger open free weight kind of types of things. And we're slower to maybe progress them. But it really depends, I think, one on age, training history, and also the kid's maturity in terms of comfort with some of those things and ability to take on a new novel task. And so yes, it does depend. But that's why I think it's nice to be able to work with a great therapist or a great team that can really customize to your child's kind of needs in terms of and what they're able to do and tolerate. I've had some kids that are 11-year-olds that are extremely well versed in some training things, and we're able to do some very advanced strengthening training things or plyometric trainings. And I've had other 14 and 15-year-olds that I would hold back or maybe apply some more constraints to. So I think maturity level plays a big part there. So yeah.
Deborah, your thoughts on that? You've obviously been training these for a long time, seen a lot of them on the field, I'm sure, and post-op and return to sport. But your thoughts, Deborah?
Yeah, I didn't get many opportunities to work with sort of real pediatric populations. I would say, from my experience, most of the process is very similar. It's just you kind of tweak things and tailor it to the individual, sort of regardless of where they are on the age spectrum. You're still going to change things up, just depending on their level of development and their experience. And some 12-year-olds may have plenty of experience with some of these functional movements, and some have probably never done it at all. And you're going to change the way that you treat them based on kind of who they are, not necessarily their age.
Yeah, I think the general principles and the goals of the therapy program are pretty universal for all age groups, but how you get there is quite unique. Different approaches work for different patients, different timelines, different exercises at different stages, but general principles and goals are the same, but an awful lot of customization in that process of getting better. So, gosh, we got 4 more questions. Wow, this is a great audience here. Jeff, I might direct this next one at you, but this is about thoughts on a return to play brace for soccer, and maybe for any sport, but return to soccer is what they asked. And their question was, is it needed? And I've been hearing mixed opinions on that.
I would say I'm not as well versed on the literature, so I wouldn't like go quoting as much. But from my experience, in my opinion, they're not necessarily as needed. Like the amount of support that you're going to get from that brace is probably minimal at the point in time that you're and at the intensity level that you're looking to participate at. And so it's really more of the work that you're doing to prepare yourself to meet the demands of the sport, and less so the having a device that's going to be there to be a fail safe. It's not going to work well to do that for you.
Yeah, and I think the literature, unfortunately, has not shown efficacy of the braces. There are people who use them. We see, the one athlete on the football field professionally is professional quarterbacks who stand up a lot and are kind of vulnerable, but don't necessarily move around a lot. They will wear ACL protective braces. But I can't think of a professional running back, linebacker, even interior lineman who wears an ACL type brace for protection. And the data has shown that for many sports has been looked at, not all sports have been studied, but probably doesn't prevent injury. The other practical challenge is that the braces, gravity tends to pull the braces down to your ankle, no matter how tightly you snug those braces up, trying to keep them right at the knee joint so the hinge doesn't bind. So your native knee hinge and the brace hinge are perfectly lined up. The brace hinge continually goes below the knee hinge because it's going down towards the ankle when you're running. And so even in athletes who try to use them, they abandon them and they're involved in high running type sports. So I personally don't recommend them unless people feel better using them. I think it's okay, but I don't routinely recommend them based on lack of efficacy or lack of evidence showing they work. Tim, we got another good question here about it, kind of maybe two questions here. One is, can we talk about ACL prevention? And the other one kind of related is, what are the top 2 exercises to do to prevent ACL tears for soccer players? So maybe put those 2 together, and then we got a couple more questions after that. But would you tackle that?
I think that's a great question. I know it's a hot topic amongst a lot of people in terms of, okay, well, how do we just get ahead of this whole process and avoid it altogether? It's really hard to do that, especially in certain higher risk sports where the risk is just a little bit higher in nature. But I think we've seen some injury prevention programs where the literature has been good, maybe mixed a little bit in terms of mitigating some ACL risk, or at least lower extremities. So the leg injury risks, whether it's an ACL or a meniscus or some other muscle strain. But I think a really common, easy one that we've seen a lot of use across the country and even globally is the FIFA 11 program. It's kind of a dynamic warm-up program that a lot of soccer programs have integrated in. If I had to recommend off a cuff to somebody I don't know, if there's something you could do, I would say it would probably be that program in terms of integrating a short 15 to 20 minute pre-warm-up, pre-practice, pre-game kind of structured exercise system. It seems to do some well, and we've seen some decent literature, I think, published in terms of mitigation of risk, but it incorporates some different balance tasks, some different on-field strengthening tasks, so a particular hamstring task, a Nordic hamstring, where the individuals are partners and they do some falling motions that seems to be doing some good hamstring strengthening work, and some other just some dynamic things to get the individuals warmed up and maybe prepped kind of for that sport activity. That might attenuate some of that risk a little bit.
Yeah. A related question on this, Tim, and first, I love your answer. FIFA 11 is, it's free of charge. You can just Google, type in FIFA 11, it'll take you right to the exercise program. A follow-up question to those first 2 questions is, what program methods are best to implement to prevent an ACL injury? So I think, Tim, you kind of addressed that. The FIFA 11 maybe goes right towards that. And there's some data showing you can actually reduce somewhat the risk, perhaps more so effective in females and males. But their follow-up question is, how many days a week should these be performed in and off season? And does it differ between males and females? So Tim, any thoughts about how often they might do this in season versus off season?
Yeah, I think that, to my knowledge and understand, the FIFA 11 is something that's probably low enough that you could do multiple times a week throughout practice periods. I think the biggest consideration with in-season programming of any sort of training is that we don't want post-activity soreness or those issues to impact performance for an individual during a gameplay situation. I oftentimes have athletes, and will recommend athletes, whether it's the FIFA 11 or something else, maybe a really simple resistance training program, even in season, if they're doing 1, maybe 2 days a week of a lift of some sort, and a couple different single leg lifts that are going to help in terms of maintenance or building some little bits of knee and hip strength. those can be really beneficial. I think taking advantage of off seasons, and I will say, I think in this area, having an off season altogether can be really helpful. I think we see a lot of kids who are playing 12 months out of the year of soccer, and we know that those exposures, that amount of time throughout a year, just increases the risk a little bit higher for injuries in general, for chronic overuse injuries, for potential injuries like the ACL. So I think sometimes, as counterintuitive as it sounds, to take an off cycle for a sport where there's high demand and a lot of high level competition in the area, it can be really beneficial and I think protective for the individual, and potentially improve some performance metrics as well if you're taking some time in an off season to do some strength training, some other cross training, some other exposure of sport type movements that are going to advance that individual's ability to kind of protect themselves and be strong and ready for the season that they are going to play. In terms of gender differences, I don't know that I do anything gender difference wise between the male and females. I think there's a lot that can be done for both groups there, and I don't know that we have to customize it that much for the two groups. So.
Yeah, I agree. Tim, I think both groups benefit from it. We do know that females, as a general rule, are anywhere from 2 to 5 times more likely to tear an ACL, depend on the sport, but with the same exposure, 2 to 5 times higher risk for females. And so I prioritize it on females, but I think it's beneficial for both. Really good idea to just build that into your year-round training program. And Tim, I like your comments about off time, because the way our body responds to training is we have cyclical training responses. And if you constantly push your level of training, you reach a point of optimal fitness, but then you start to deteriorate. It's hard to maintain optimal fitness year round. And so by giving people off cycles, and sometimes it's a 2 or 3 month rest period, they switch to another sport, or they do a casual recreational sport, but they back off of that high level sport for a while, is helpful. And many of the best programs, they actually will train the kids 3, 4, 5 weeks hard, and then they have a week or 2 of recovery built into their training program, built into their game, their travel schedule, knowing that the body, you can push its fitness kind of up a stair ladder, case more fit, more fit, more fit, and then you reach a plateau. And if you keep pushing them, the fitness deteriorates. And if you give them some recovery time, you're able to push their fitness a little higher. But rest, nutrition, recovery time is just as important as becoming a better athlete than training harder and harder and harder. And some coaches say, you become more fit during your rest time than you become more fit during your hard training time. Too much hard training breaks down fitness. So you have to push that balance just about right. So Deborah, there's a question they called you out. So Deborah, what advice would you give to those players that are mentally not ready to return to sport even after the 9-month mark? And Jeff, I maybe have both you guys take, because you guys are athletic trainers. You're the one who sees those kids 8 months, 9 months, 10 months later, and you see the kids are not quite ready mentally. Thoughts, Deborah, and then you, Jeff.
Yeah, I think if you're getting to 9 months and you feel like potentially you're not mentally ready, or you still have some fear about returning, it's probably important to make sure that you're not justified in having that fear, and make sure that you're physically ready in terms of your strength and kind of some of those more objective measures. I feel like people who get to 9 months generally probably and are mentally not feeling ready probably had some moments throughout their rehab where they weren't feeling quite mentally ready, and had some of that fear avoidance, and may have been a little bit behind the curve. So I wouldn't necessarily use the 9-month mark as like you should be ready at 9 months. I think it's very typical to not be mentally ready at 9 months, and it's important to kind of grade your exposure gradually over time to some of those more complex and more precarious positions, and start off slow and make sure that your technique is really sound, and gradually sort of make some of those more higher risk drills more complicated, and more increase your speed gradually over time, and introduce external stimulus gradually over time, and not think that you can go straight into that just because you've gotten at 9 months. I think there's still quite a bit of work left to do at 9 months in terms of the mental component. And if all of that fails and you're still struggling, I think that talking to a sports psychologist is a really a great option for you, and probably a smart thing to do.
Yeah. Jeff, you've been doing this a long time, seen a lot of athletes trying to get back. What are your thoughts?
Yeah, and a lot of work with high school athletes, so I think this group fits well. Like a lot of times what I see with that age group is, maybe they haven't been pushed hard enough in therapy or rehab, and so the expectations are set very well of like, you know, what do I need to do in order to be successful to come back to the sport? And they kind of just think like, I'm just waiting and I just keep twiddling my thumbs doing a few of these exercises. And then when I hit that time period, I'm going to be ready to go. And it takes a whole team of people, I think, in your rehab really pushing you. It takes the athletic trainers to help you, I think, grade your exposure in coming back to those sports. And so it's not as if you go to the surgeon and you get a clearance note and then you're going right back to a game that night, because we're really setting you up for a bad outcome, setting you up for failure, not just even ACL wise, but just performance wise, because we haven't prepared that person enough when they're coming back. So I really think it's, you know, getting pushed hard in your rehab and coming along, you know, gradually and building that exposure so you can build confidence. And I think one thing that works really well in the setup that we have is, you know, we're doing our return to sports testing with individuals at the same time and in the same location that all of our early rehab, ACL rehab participants are in. And so they get to see what the expectation is, like what we want them to be able to perform well. So they get to see what they need to do essentially to graduate. And so I think that's very helpful for them to see that high level testing and think, all right, well, this is the goal. This is what I got to get to. And sometimes we have people who come that haven't had as good of access to rehab, who they really struggle when they come do the return to sports assessment with us, because it's just like a very big shock to their system.
Yeah. I love both those answers, Deborah, Jeff. Clearly, you guys, you've been doing this a long time. It's not your first rodeo. So, interesting question. Erwin Chong, I hope I pronounced the last name correctly, but Erwin, really nice question about, do you see acupuncture benefiting these injuries? I don't know the answer to that. I do have a little experience where I've had some patients who have struggled a little bit with stiffness or pain, not just from ACL injuries, but from other things. And acupuncture seemed to really help them sort of break through some of that chronic cycle of pain. And so while I don't know of any studies on that, I actually think there may be a role in select patients for acupuncture and other modalities. You know, traditional medicine doesn't have all the answers, and sometimes non-traditional medicine can help. I don't think of acupuncture, as long as it's done by someone who's qualified, I don't think of it as a risky intervention and probably not terribly costly, but it may help in some cases. So I think it's a reasonable adjunct. I don't use it routinely, but I have had some parents and some kids who have struggled with motion sickness or other things, like I said, not just from ACLs, but bad ankle injuries or other things, and they seem to respond nicely. So there may be a role for acupuncture, and maybe that's a nice research thing for the future. We have another question. I'd like to continue on. In fact, Jeff, maybe your thoughts about this. The question is, let me piggyback off the brace question. Does Kynotape fall into the same category? Thoughts, Jeff, about kinesiotape, K-taping?
Kinesio tape definitely falls into the same category, as that it doesn't really provide you much serious benefit, especially if we're talking about any kind of stability or protection. And if you look at a lot of different studies on kinesio tape, looking at performance or other things, it's not particularly it's not going to give you a lot of benefit. It's really more of a placebo type of activity than it is any kind of real benefits you're going to get from it.
Yeah, I kind of agree a lot what you say, Jeff. And the one comment I will make, though, is I think, like many things, the placebo, even though a placebo means we don't really understand how it works, but sometimes 20% of the time people get better with an intervention, even though we can't explain why that is. And so I tell patients that certainly trying a placebo, whether it's an e-sleeve or kinesio taping or other things, that if you're one of those 20% who feel better, feel more confident, feel more comfortable, whatever the benefit you get, it's probably relatively low cost and very low risk. And so sometimes we try that as an adjunct, and sometimes it works, sometimes it doesn't. But if you're one of those people who responded positively, I think it's a reasonable thing to try, but it's not something I think there's a lot of good support for it, as you mentioned, Jeff. But it's low risk and relatively low cost, and parents can learn how to do it, and kids can learn how to do it as well. So there's a lot of professional athletes who swear by it, and some professional athletes are actually sponsored by the kinesio tape companies. And so I don't think it's harmful. I'm not sure how beneficial it is, but some people like it. And Deborah, you got a little smile on your face. I think you're maybe maybe you have some thoughts about placebo effect in many things in life.
I mostly agree with everything Jeff said. It definitely it doesn't have enough support in the literature, I don't think, to really push it. But I'm a fan of sometimes you try anything that isn't going to hurt, and if it's not going to cause any pain, and worth trying out a time or two. If it doesn't help, then it doesn't help, and if it does, then great. It's yeah, like Dr. Shea said, occasionally you get one of those people that does benefit from that placebo effect, and if you're not doing any harm, I don't really see the problem with it.
Yeah.
I think as athletes, we've both, in many times, put some tape on something for somebody who had some sort of ailment, and it made them feel better. And we'll just keep doing it because it helps them perform, whether or not we actually really going to be to their benefit or not. But if it helps them on game day get in the right mindset, then yes, I guess we're doing it for them. So
we don't have hard science for everything, and we kind of listen to people and patients and families, and willing to try other things as long as it's not potentially harmful or real costly. So, gosh, what a great audience! My gosh, we got all these great questions. The next one, there's some complexity here, but I'm just going to read it to you. How important is it to sway kids into multi-sports instead of what seems to be more popular today, and get away from, quote, sports specialization and doing just one single sport? Where can I find data to back up multi-sport athletes are lower risk to injury because of the stimulus of other muscle groups and other ways? And great question. I'll just offer a few comments. There is some data. Emily Krause knows a lot about this. Dr. Krause, one of our primary care sports medicine doc, does a lot of work on overuse injuries. And there is data on sports specialization and absence of breaks from the sport. You're more prone to overuse injuries. Whether or not you're more prone to ACL injuries, we're not sure about that. There may be some fatigue issues that develop with overtrain, and fatigue may clearly lead to an overuse injury, but may also lead to traumatic injuries due to absence of muscle vigorous response, such that you have enough fatigue that you're more likely to tear your ACL because of weaker muscles, muscles with endurance that is yielding earlier in the training session or the sports competition session. So, but yeah, you could do a Google search on this, and you will find there's a lot of stuff written on sports specialization and overuse injuries. And there's also data on looking at a lot of elite level athletes. A lot of elite level college and professional athletes actually were multi-sport athletes. There's a lot more multi-sport athletes who later in life became single sport elite level athletes, but there's lots of single sport athletes at a young age burned out emotionally, psychologically, or had overuse injuries that prevented them from doing that. And baseball and gymnastics are two great examples of that. So, some sports specialization, you almost have to do it. Gymnastics is one of those examples, but for many sports, a diversity of sports exposure at a young age can really be an advantage. And if you look in the NFL, I'll give you an example, a lot of the NFL's best tight ends and some even wide receivers were actually superlative high school and maybe even college basketball players who then turned into football players. And because of the skills they developed with their hands, their body position, their foot position, their pass route running ability really was developed because of their basketball skills. And so just something to keep in mind. But yeah, I think it's a really good question and a lot of data on that. You go to Google Scholar or PubMed, you can find some stuff about that. Sergio Correa, thank you for the question. I'll just read it to you and I'll let Tim tackle this one. Myth or fact? Does longer warm-up stretches lead to a higher risk of tear?
Great question. I think what we're getting at maybe is there had been, some discussion and looking at longer static stretch holds and injury risk potentially. So those long, just like hamstring stretch for 30, 45 seconds just prior to maybe a sprinting task or some of those things. I don't think that we've seen anything to my knowledge in the literature in terms of risk for tear of an ACL. I think there's been some mixed data potentially on some of that being detrimental performance effects for sprinters and things like that, where you're doing long duration hold stretches. I think more often what we will recommend and try to integrate into our training, and then also with our kids going out then future training wise, is some sort of dynamic warm up that's going to be a graded version and mimicking the tasks that they're going to be doing. So if they're doing a lot of jumping because they're going to be playing volleyball or basketball or something like that, maybe there's some jumping kind of tasks that are warming up those knees and hips and the muscles and tendons prior to then going to an all-out effort in a gameplay situation. Or likewise on the soccer field, that they're doing some dribbling drills or some running drills, something that's going to mimic some of the maneuvers that they're going to be doing then at a high level in the next 20 to 30 minutes. We want to get them warmed up with the tasks, with the muscle tissues and the tendon tissues and the ligamentous and the joints, kind of getting those all comfortable with that. But to my knowledge, not a higher risk from that standpoint, and strictly looking at the question like that.
Yeah, really interesting question, Sergio. And we have so many good questions like this, and we don't have as many answers. But I think the future of wearables and tracking is really going to help us understand some of these things over the next 10 to 15 years. So ask me this question again in 5 to 10 years. We may have some wearable data that tracks warm-up time and injury risk, including injury prevention. One thing to add on with Tim is I don't know about warm-up and acute fracture or ACL tear injury prevention. I don't know about correlation there, but there is some data that suggests that muscle sprains are less likely in a muscle that's kind of warmed up a little bit. As your muscles are cooler, your muscles and tendons may be a little stiffer, and during a sudden stretch or a centric load on the muscle, a stiffer muscle may be more likely to have a partial tear or even a more significant tear. So warming up maybe plays a value in muscle tendon type injuries. I'm not sure about ACL injuries, but really good question. We have 2 more questions and about 5 minutes ago, so I think we got enough to handle these last 2 off. I'm going to take one. And one is do you have a chart of ACL injuries by sport? And I don't have a chart, but I can tell you I kind of break sports down into high risk, medium risk, and low risk. So high risk, soccer, football, basketball, lacrosse, wrestling. And there's a sport called team handball, which is a combination of soccer and kind of volleyball. It's a weird sport in Europe. Also, that has the highest risk of ACL tear of any sport known. But those sports, pivot, shift, accelerate, change, evade other athletes on the field, boom. That's where you tear ACLs. Volleyball, middle risk sport. Baseball, middle, maybe lower risk sport. So those are kind of on that lower category. Field hockey, women's field hockey has a relatively low risk, and maybe that's because women in field hockey, they're bending over on the field and no one's tackling their knees. And so they're not kind of as likely to get their knees torqued out. Cross country, track and field, swimming, golfing, cycling, very low risk. And so one thing you can think about, if you're a mother or father or an athlete who's had an ACL tear, maybe 2, many times athletes who injure their ACLs are really good athletes, and they can switch to a lower risk sport if they want to mitigate that risk in the future. So great. Next question. Well, we keep getting questions popped up here, but Tim and any of you guys, but is there evidence these new cleats advertised to decrease risk of ACL tears actually prevent injury? So there's a Nike Phantom and others, but anyone want to take a stab at that one?
They have whole biomechanics, bioengineering departments that look at cleat interactions with turf and different turf surfaces, different cleats and different cleat patterns. I don't have any specific information on there, but I do know, that the general goal is for the turf, especially since we have a lot of introduction of artificial turf, to act a bit like ski bindings, where it holds you here until it gets to a point where it's dangerous for you, and then has a release. And so, there are probably some information out there on the new cleats that Virginia Tech has, like helmet ratings, and there's probably a cleat rating system that's either developed or in the works. I would imagine. I don't have any specific recommendations to say one way or the other, but it is a problem that people are working on, independent of the shoe companies.
Yeah. Great question. Mike Coughlin, an orthopedic surgeon in Boise, Idaho, I used to work with, he did some work at Boise State, developed a cleat surface interface studying device, and he actually took it around to multiple stadiums in the NFL about 10 to 15 years ago, trying to do some research on that. But there's so many variables involved: body weight, position, long cleats, medium cleats, short cleats, turf, what type of turf, grass. So many variables, it's hard to study that. But I think that's something in the future with more wearable data, we'll have better answers. Deborah, I got a question here for you as we're trying to wrap up here, but are there some premature signs of weak knee or ACL? Another good question.
I guess like the quad hamstring ratio would probably be something to look at. If you have significantly stronger quads than your hamstrings, in terms of what Tim mentioned earlier, the 80% body weight on your quads, 40% on your hamstrings, that certainly would be something that you would want to address. That's really the only one that really comes to mind in terms of like premature alignment, maybe a little bit. Some of your natural kind of anatomical features and how much genu varum and whatnot you have. Those are kind of the only two that pop into mind right now.
Yeah, no, just a rule of thumb that I look at, I sometimes look at athletes, and if you look at an athlete from the side, many athletes have pretty well-developed quad. When you see that front muscle looks big. You look at the back half of the leg and you look at the gluteals or the buttock area. If the buttock area is not relatively muscular and there's not kind of a rounded hamstring contour, if the back of the leg is flat, that's usually kind of it's a crude sign, but I'll look at athletes sometime and I'll say, hey, you would benefit some more aggressive strengthening on your hamstrings and your gluteals. And you can meet with a physical therapist or an athletic trainer to drive a training program that'll build stronger hamstrings, because hamstrings and gluteal strength are pretty critical for the way you jump and land to change direction. And there's some data that hamstring strength may be one of the most critical things to prevent ACL tears. And maybe one of the reasons ACL tears are more common in females is, as a general rule, male hamstrings. You look at a male soccer players on the field, you look at the back of their hamstrings, they got that rounded contour. You look at the back of the female hamstrings, a lot of times they're not as well developed. And so I don't know if that's the accurate answer, but I think looking at legs, because lots of soccer players have well-developed quads, male and female. But a lot of times the females, gluteals, and especially that hamstring contour, which suggests a big, robust, strong hamstring, is not well developed. And a therapist or athletic trainer can really help you with that. A couple last quick questions. Thanks for all the great questions. I'll try to hit these real quick. Is there a genetic component that should be considered? If mom had an ACL tear, is child more likely as well? Well, we don't know if it's genetics or it's family. Athletic mothers tend to have athletic children. Athletic mothers tend to tear their ACLs, and athletic children tend to tear their ACLs. So I don't know if it's your genetics. I suspect it's probably the fact that you're a very athletic person and you inspired your kids to do sports as well. Maybe there's some genetic anatomic component, but I suspect it's more environment than a genetic or something like that. Last question is about nerve damage, numbness from the procedure. Is this reversible? And if so, are there some proven approaches? That is a great question and getting a lot of attention right now. There are some questions being raised about the use of nerve blocks and whether or not nerve blocks should be used routinely, because nerve blocks may leave you with some subtle muscle weakness or some subtle sensor changes that doesn't fully recover. That's going to get a lot of attention over the next 10 years. I'm actually part of a national study group that's actually looking at that question right now in a 10,000 patient database across 20 different children's and adolescent hospitals. And so ask me that question again in 3 to 5 years, but that's getting a lot of attention right now. And it's a really good question. So, well, great. Gosh, guys, those were fantastic questions. Love the presentations. Deborah, Tim, you guys killed it on the answers. Jeff, great to have your insight. You've been on the field for so long, so it's just wonderful to have. We got a lot of experience here. We must have 45, 50 years of experience, maybe even more on this call. So it's really wonderful to learn from you all and have such a perspective on these great questions. So thanks to the audience. Really fantastic.
Thank you, everyone. Sorry we couldn't get to all the questions, but if you have any specific questions to your child and you'd like to schedule an appointment to learn more or discuss further, I put our phone number in the chat, 844-41-ORTHO, 844-416-7846, or you can visit our website, ortho.stanfordchildrens.org, and you can find out more there. And we are recording the webinar, and we will be sending it out after the fact.
That'd be great, Amy. Having recorded this, and what we can do is we can put it in our patient education notes and Epic. So we'll just have a link to this for families who want to listen to this. I think it's a really helpful tool for post-injury recovery back to sport. So thanks, everyone. This is fantastic. I learned a lot.
Thanks, everyone.
Double thumbs up.